Dr. Alok, this one.
Yeah, absolutely no doubt about it. You have sliding there.
Yeah, but this is barcode now,
Yeah, it is a
right?
barcode. And the question that I would ask is, first of all, there are two possibilities over here. So you're kind of in a situation where you're using a very advanced machine. And when you use a very advanced machine, if the harmonics are on, what the harmonics do is they actually reduce the artifact. Now, if I explain, it's a beautiful case to show everybody. So we're just going to give everybody 5 minutes, Dr. Ashraf, because this is such a beautiful case. I don't want to miss the teaching point. Should we look at all your slides?
Yes, okay.
So we'll go right from the
I,
beginning. It's a beautiful case.
okay. بس let okay.
It's something very common. It's something that I see. It's something that all of you will all see and leaves a lot of confusion. I'll explain why.
يعني زي the sliding يعني
Yeah.
I consider to the all blue line this is good sliding there. If you see this is good sliding this
Yeah,
one.
absolutely no doubt. So yeah, if you just play the image again, it's
Okay.
coming
I
as
just
very dark for some reason.
لا I make this dark because of all for blue line.
Sure, sure. Yeah. No doubt. Yeah, yeah.
Yeah.
I mean, there's no doubt about the sliding. So
Okay, but I will get
let's see
the
the actual barcode sign.
make it I will not make it at the full screen to عشان to I
Sure.
will see okay.
Yeah, very nice. Beautiful. So
Maybe this one maybe part of some يعني maybe he not sliding there.
no,
But
I'm not convinced. Let's go back.
بس should I do not full screen I will manage this best by a different
Sure.
way. Wait, that's the see this one. So المشكلة إن أنا عاملها فول سكرين.
Yeah.
See, I see there's maybe there's me. Okay, this is
So
the one.
there is no doubt you have sliding everywhere. Now, the problem that you're facing in this particular situation is your depth. Can you see how you're losing out on depth? So after 2 centimeters, where you have,
Now three,
yeah, but
three only four.
that's true. But look at the depth. What is happening beyond two? You're losing everything.
Yeah.
Now, the problem that you have in this situation is because you're losing out on depth, you have sliding there, you have shimmering, but you have only two reverberation artifacts. So I'm just going to draw on this so that everybody can understand. So really what you've got here is the pleura, which is sliding. Now, at the moment, the frequency you're using is giving you a very, I would say, good overview of the superficial part of the lung, but you're losing the deeper part of the lung. Now, the challenge that you face is that you've got two A lines. You don't have a lot of reverberation artifact that's actually becoming less. So for that reason, you're missing out on a seashore sign. You're actually seeing bits of the seashore sign that you can see over here, but because you've got very little reverberation artifact, that's one reason. And the second reason is at the moment you probably have your harmonics on. Now, when you have your harmonics on, the tendency is for the machine to reduce your artifact, to prevent reverberation artifact from coming back. And for that reason, sometimes in situations like this, what happens is you will get what looks like a barcode sign, a good marker that there is sliding is these areas. Can you see these areas here? So if you have a pure
Yeah.
barcode sign, you should have a pure barcode sign throughout. I think if you were able to turn off harmonics and if you're able to reduce your frequency just to get depth, then what you will be able to see is a better pleural slide. And that pleural slide will then represent better with, because the seashore sign presents with an acute demarcation between pleural sliding and the distal area over here. which technically is not sliding. That's why you get this appearance. And over here, I think it's because you can only see the superficial areas with your harmonics on that you're getting an artifact. For me, absolutely no doubt. Again, if you ever get a situation like this, there are four things that I do. The first thing that I do is I will take the probe back off. I will make sure that if I'm using a linear probe, you can all see my hand over here, that you've got gel that is all the way through. The other thing that I will do is if I'm losing depth and I particularly want to rule a pneumothorax, you can just focus on this particular zone. So you can actually reduce your depth. So come back out, concentrate mainly on the pleura, go back to M mode for that zone over there. Or alternatively, you can reduce your frequency to get a better image penetration. If you're using an old machine, harmonics will not be a problem, but you might have to take two areas of focus. You might have to have an area of focus that basically looks at the pleural line and an area of focus that looks slightly deeper. But this is a very common kind of thing that I see. I especially see this when I use my GE machine and harmonics is on. And really, in this situation, I would always go with what I can see. And there's no doubt. I mean, I can see pleural sliding all the way through up till here. I can't delineate much to the extreme right over here, but I wouldn't interpret that because this is just one intercostal space. We're basically doing a
Yeah.
scan in the intercostal space. I can see sliding throughout. Again, you've done absolutely the right thing. And this is the beauty. I mean, Dr. Ashraf is very, very experienced. But if you're confused about a particular area and you're doing uh, a scan that's perpendicular, go back to each intercostal space. And on Sunday, I'm going to show you how to track intercostal spaces when we look at lung recruitment. But the idea is that you can actually go to each intercostal space and look at sliding in each individual area. And you can do it very quickly by what is called, it's called a sweep.
Yeah.
So that sweep, is what you've done over here. So there's absolutely no doubt that what you're probably getting is what I'd call is a pseudo barcode sign.
I think the other twin the same issue.
Yeah,
Uh, yeah, this one. See this nicely.
yeah,
This is nicely pleural sliding here,
yeah,
also over there,
yeah, no doubt.
also here.
Sorry, I'll just
This is
rub.
also the same barcode. I think the dipsy now is okay now here.
Uh, yeah, I'd say till two, yes. After two, we have a lot of dropout, and
Yeah.
that's what you're seeing in this region here. But what you're seeing is basically A-line artifacts. Your harmonics are on. But if you,
Mhm.
again, if you could enlarge that image, I'd be so grateful. Are you able to?
Large image.
The one with the barcode
Uh,
sign.
we cannot.
No problems. So I'll just highlight on this. So can you see this region here, and this region here? They, 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 these are actually sandy beach appearances in between. You'll never get that if you get a true barcode sign.
Yeah. Yeah.
Again, you can see that over here as well in this entire area. So if you're getting an artifact like that, take your probe back off, make sure it's gelled, take it back on again. If you're
Decrease the frequency.
you can
Mm.
decrease the frequency to get better depth. Naturally,
Yeah.
as the A lines, so normally what happens is experience usually says that when you have a pneumothorax, the pleura and the air interface is a massive reflector. So you get A lines all the way through. But let's say you have shimmering and sliding. Often the A lines basically reduce in intensity as you move down. And that basically gives you this appearance of, I would say, the seashore. So it's a little
Mm.
bit of manipulation. But again, if you're confused, go to each individual space, mark your way down. And if you can say sliding in all those spaces, and again, clinically correlate. Again, what I'd say is that if your baby's not got much in terms of respiratory distress, the one thing that Dr. Yusuf, that Nadia will talk about when she talks about POCUS is what we call air bubbles. Now, air bubbles, and I will show you a case towards the end of the course. maybe a small area, like you've got sliding on this side, you've got sliding on this side, and you have a small pocket where there's no sliding. And what you can see is you can then see the interface between M mode of a seashore sign on one side, a seashore sign on the other side with a barcode in between. Now, the other thing that, I'm kind of why I think this is pseudo barcode sign or an artifact is I cannot see that. I cannot see seashore sign anywhere in this region and anywhere in this region. So this is not even a bubble. Like if we say that there's a small area, then really what we should see is seashore sign with a barcode in between. So uh, I think, your experience is really very good, Dr. Ashraf. Uh, uh, your images are also very good. My compliments, and I'm so grateful. Thank you for sharing this case with us today.
Very good. Just بس I want to share to see there's no pneumothorax,
No.
but that's what I saw. I love to share with other.
Yeah. So if I summarize for everybody, if you feel you have a baby who's not symptomatic, where you can see pleural sliding uh, on M mode and you get a barcode sign, is the probe in contact properly? It usually is in contact properly because if it wasn't in contact, you wouldn't get the top image. The second thing to do is lift the probe back up, apply gel throughout its entire interface, go back on again. If still confused, make sure you're not losing out on depth. If you have a machine that has harmonics on, try to switch it off. For those of you who don't kind of know about harmonics, what I would say is it's really important for you to get your techs in to kind of show you. So in our machine, again, something that I will show you on Sunday, uh, harmonics has a completely different interpretation. It's basically called speckle reduction imaging, SRI. And really what I want to do is I do not want to make that very high because what it will do is reduce artifact. Again, some of you have joined us late. Alberto has joined us late. Alberto's just joining us. Dr. Ashraf, I just want to show this to him as well. Alberto, can you hear us?
Yes, yes.
So Alberto, I think some of you have just joined us. This is a beautiful case that Dr. Ashraf has shown us. And we're just concentrating on the middle, the right posterior lower zone. So what you can see is this is an intercostal space. And this is the same uh, multiple intercostal spaces. And that what you're doing here is you're doing a longitudinal scan. What you're doing here is basically a transverse scan. And what do you think about the pleural sliding? Is it present or absent?
In the middle one?
So this one.
This one. I think it's absent.
Okay. Dr. Ashraf, you can't make this larger, can you? The middle one?
But I can stop. I can stop. I make it as larger. I can stop.
Sure. Okay.
Just was
Sure.
few minutes. Okay.
So Pauline, you'll go next, and then Dr. Ashraf will share his other cases after you. Is that okay?
Would be perfect. Thank you.
Really, I can. Should I minimize the screen? I cannot make this as well.
Or what you can do, Dr. Ashraf, is are you able to play the top image? Yeah, this one. So, Alberto, what do we think about this image sliding?
The top of it?
Yeah.
The top of one, yeah? Top
Yeah.
one?
Yeah.
I think there's a sliding at the right side, but in the middle, I have not so sure.
Okay. I mean, I can see sliding throughout. And what we're getting at the bottom here is what is a barcode sign.
Yes.
But again, these are all images of the same regions. And a good example is, can you see the image on the left here?
Yes.
There's sliding. You happy?
Yes, there's slide.
Yeah.
Yes.
So there's sliding over here. There's sliding over here. The question is whether there's sliding over here or not. With the eye of faith, I think
Yes.
there is. Uh,
Okay.
but you're getting a barcode sign.
Yes.
And we were just discussing why that might be the case. Now, a few reasons for that, obviously, from our perspective at the moment, you might have a machine where harmonics is switched on, which tends to reduce your reverberation artifact. Now, theoretically, in that situation, you may make sliding more difficult to visualize, but you're also losing the deeper area of your kind of image at this particular stage. And when you do that, you kind of tend to lose out on the beach. The seashore is still there, but you're going to lose out on the beach as the A lines tend to get more attenuated as you move in. So the few things that we recommended, that if you're confused, one thing that you can do if you're basically looking at multiple ribs is to go into each individual intercostal space and look at sliding in each individual intercostal space, because you might be able to
Okay.
pick up an air bubble. So like you said, you're worried about the middle area, maybe not showing sliding. So what I would do is I'd go into each individual intercostal space, basically doing transfer scans up to down. And if I can see sliding with a seashore sign in all those areas, then I'm absolutely certain that this is actually an artifact because of either the fact that maybe harmonics is on. The other possibility might be that I haven't got gel on the entire probe in its uniformity. Uh, but if you have an air bubble, which is a small area, that is a small pneumothorax in the middle of different, I would say, areas of sliding, a small anterior pneumothorax, then what you should get is a seashore sign alternating with uh, the uh, the
Barcode.
barcode. But here I'm seeing a barcode in its entirety. And the fact is that actually there's sliding everywhere.
Yes.
Now, this is, I agree with you, one point. So the other thing that you could do is move your cursor around just further, just a little bit
Mhm.
here or there. Uh, the challenge here is you can see sliding everywhere. So this is the same region, probably magnified, RPL,
Okay.
and you can see sliding virtually everywhere. So if you're confused and you're getting a barcode sign, again, steps, go back, take your probe off, align again, ensure there's adequate amounts of gel on it, ensure that your harmonics are switched off so that you're not minimizing artifact.
Mhm.
For the GE machine, it's called special speckle reduction imaging. So it ranges from 0 to 5, and usually I will keep it at 0 or 1. But on the GE, that's what it's called. I think that's what it's also called on the Sono side. Uh,
Yes,
and
my,
then,
my decision was made on the M mode. Yes,
yeah,
because
sorry, I missed your question.
I said that my decision about the sliding was made based on
On
M
the M
mode
mode.
because we
Yep,
can see a
a
beautiful
barcode sign.
barcode.
And
Yeah,
you
yeah.
have to be very cautious, a little bit
Okay.
cautious, I'd say. Just again, the important thing is we would stick to the protocol. The protocol would be we'd always look for sliding, we'd look for the profile, which is A dash. We would then look for, and this is really important. Let's say you get a barcode sign in this one particular area. If it's a small to moderate pneumothorax, you must look for the lung point.
Okay.
You must look for the lung point. And a lung point can be demonstrated from above downwards or from medial to lateral, depending on the baby's position and the size of the pneumothorax.
And do you consider a lung point in the upper?
Yeah, so let's say if, can you see me?
Yes.
Okay, so let's say I've got a small pneumothorax that's extending all the way down here. I might have
Mm-hmm.
air in this region, but I might have absolutely no pneumothorax in the rest of the lung. It might be so small. So my lung
Okay.
point will be lateral, but it will also be inferior.
Okay.
But if you have a large pneumothorax and air in a supine position accumulates anteriorly, eventually you will lose sliding in the whole of the lung anteriorly, and you would be tracing the size of the pneumothorax in such situations by moving towards the anterior to mid to posterior axillary line. What I'd say is that once you start losing sliding in the posterior axillary line, That's quite a large pneumothorax.
Okay.
Yeah.
Thank you.
Dr.
Any other?
Alec, it is
Yeah.
good. Dr.
Yeah.
Alec, it is good when I do it, I make it darker for all part except the pleura to
Yeah.
see the sliding like this. It is obvious sliding here.
Yeah. Yeah. No doubt. I completely agree. And that's one good way that you've kind of exemplified it. I think the other way to kind of, I'm just giving you tips. You could make the baby cry a little bit. Gently. So, in situations like this, if the baby's stable, I wouldn't want to do that if you've got a very big pneumothorax because it might make the baby worse. But if it's confusing, you can tickle the baby's foot, anything that makes the baby breathe a little bit faster to make the sliding more prominent. So, small things that can help you in that situation.
Thank you.
Dr. Ashraf, I'm just because Dr. Pauline wants to present. She's on
Yes,
call.
no problem. I am just, but I tell the audience all coming. I do make this. Okay, I will
Sure.
stop shares.
God
I
bless
will
you.
stop shares. Yeah, thank you.
Yeah, thank you very much. I'm very sorry I was late.
No,
Uh,
please don't apologize.
I will just try to share my screen. Do you see it?
Yes.
Okay, I will put it in this mode. So I want to present a case from a term baby with a good birth weight that I saw for the first time on day 2. He had a postnatal diagnosis of a left-sided congenital diaphragmatic hernia. He was intubated, and his pressure that he needed was very low. We put him on volume guarantee, 5 mils per kilogram. He had max 25% of oxygen with quite low inflation pressures and a PEEP of 4. He was curiorized and sedated. This was the X-ray that was done on day 1. And then on day 2, I did an ultrasound where you see on the right side on the upper part, you see the thymus.
Very
and
nice.
No pleural sliding, the bat wing sign, no pleural sliding, and the thymus and the heart next to it. And if you go to the anterior axillary line, also on the upper part of the right lung, there you see lung, you see bat wing sign, you see lung sliding with, and you see an A lines, you see some common tails and some B lines.
Yep.
For me. And then if you go to the lower part, then I
Very
also
nice.
see bat wing sign, pleural sliding, A lines present, common tails and B lines. And on the lateral side, I see a very good A profile with the same bat wing sign and sliding and some B lines. And if you go to the left side, then on the upper part, you see also a bat wing sign, the pleural sliding that is present, a pleura that is quite small. I see A lines, B lines, and some comet tails. And when you go to the lower part here, you see, for me, a double long point. Here you see the pleura with the sliding and some B lines. And over here, you see the presence here, and here you see presence of intestines.
Yep.
And in between, sometimes you see, for me, a bit of lung.
Yep, I agree.
That is in between, but with no pleural sliding. So there's a little bit of air, I think, in between. What you see?
Yeah, it's possible. Did we do an M mode?
No. Yes. I did an M mode, but because it's an image, I didn't do it in the presentation. But I saw a barcode sign.
That's fine. Then that confirms. Absolutely.
Yeah. And then when I went to the lateral side, I also saw a double lung point with an A profile, some B lines, some lung sliding, and then over here, for me, I think, but it's quite difficult to say, because here I think it's the heart, but on the lateral side, I cannot explain how I can see on the left side the
What
heart.
you might have at that particular point is, I mean, it doesn't give you a bowl-like appearance, but it may be that you've got an organ there
Mm-hmm.
of some kind. Was the liver up on the left side?
No, no,
I mean,
but
the
maybe
only
the spleen, I don't know.
possibly, it's definitely an organ of some kind. Maybe,
Mm-hmm.
you know, an angle of the spleen. It doesn't look like bowel, doesn't give me that appearance. It's very
No,
tissue-like.
yeah, indeed. And I was wondering, is it liver? But that would be strange because it's not up, and
Yeah.
for a thymus, it's also not the position
No, absolutely right.
of it. So maybe it's the spleen, indeed. And then the patient got operated. This was the first X-ray post-operative, where you see the lung, but also a lot of pneumothorax, or a lung that didn't get recruited due to lung hypoplasia. But what I was sending yesterday in the group was, after this X-ray, here you see more air.
Yeah.
And we were just wondering, the patient was quite stable for his ventilation, but it was difficult to see. We see midline shift, and we were wondering, is it a pneumothorax? Is it pneumomediastinal air? We were just wondering,
So,
what is it?
yeah. So if I kind of describe my thoughts, and it'll be very interesting to see what others think, because we've got a huge group of very experienced people. So experience says that that area over there looks like you've got an element of lung, because there are markings, and then it's very loosened, definitely in this entire area up over here. A very sharp heart border. Now, once you've got a very sharp heart border, there's got to be an element of a pneumomediastinum, is my experience. So that heart border being that sharp with the lung, that's the medial border of the lung outlined with the border of the heart. So that's probably a pneumomediastinum with decent lung, I'd say, visible here, and anterior air. Now, often we describe this area. Can you see the marking there? And what my radiologists, when I used to ask them, they think they basically call it herniation of the visceral pleura. So because you've got a significant
Yeah,
amount of air, the pleura tends to herniate to this side. And that's basically, it's very similar to the kind of line that you see when you have a perforation and you have the ligament of Teres outlined in the liver. But I think what you've beautifully demonstrated in this X-ray is the anterior pneumomediastinum. And it's so beautiful that you guys are getting lateral views. That's an anterior pocket of air just in front of the heart. It's beautiful. Not babies.
And then they said, you are following the course for lung ultrasound. Can you look with the ultrasound machine if it's mediastinal air or is it pneumothorax, and what we have to do? I thought, no, I can't, but I can try, and I can make some good image, I think.
Yep.
So I did an imaging on the right upper side, so normally the good part, where in the beginning I see on the in the line of the nipple, so in the middle, mid clavicular, I looked, and there I saw, for me, an A dash profile with no significant pleural sliding. And if I went to the anterior axillary line, I here saw, for me, a thymus.
Yep.
With more axillary here, a lung, and on the other part also, for me, lung tissue. But it was difficult because it's a quite small footprint, the hockey stick that we have, and I didn't try it with a large one. That's what I'm thinking right now. But maybe if I used a larger probe, I could image it better, the two parts.
Coming back to the right upper R1, were you feeling it's an A dash profile?
Yeah, I was thinking it.
Mm.
I didn't do an M mode on it.
I think that's really, really important.
Yeah.
The only reason I kind of say, and I agree, sliding is not, it's not typical. It's not easily visible at this particular point of time. You do have A lines, which would indicate well aerated lung. The only thing I'd say, the question is whether there's lung pulse there. Now, if you have lung pulse, I'll just show the region that slightly worries me, just there. The question is, that is also a sign that would technically exclude a pneumothorax. There's a little bit of truck sign, and that's why it's absolutely essential. We definitely do the barcode sign.
Okay.
Yep.
Yeah. Okay, good. And then on the lower part here, I found it very difficult to know what I saw. I didn't get a better image of it because it was difficult to. The heart was also there because it was
Yeah,
shifted.
it's a beautiful image. Can I just say the quality of your scan? It's so nice. The skin, subcutaneous tissue, the ribs, the pleura. For me, there is sliding. Uh,
Mhm.
uh, I think the reason you're getting this artifact is because of the heart. And naturally, if I put two and two together, you probably, from our perspective, have a pneumothorax on the opposite side. Hence, you're starting to see heart on the right side
Mhm.
because it's probably pushed. You do have a dominant A profile, but I can
Mhm.
just see the occasional comet tail at the top. So I'm just going to highlight where. So just that region there. Uh,
Yeah.
Again, just there, very small. The M mode would definitely be very important.
Mhm.
Very, very important in this
Yeah.
situation. Yeah.
Yeah. And when I looked on the lateral side, I saw a fine A profile with some
Yep.
comet tails and some B lines, and then I looked retrosternal to see if I could screen in between, and there for me I didn't see um, any sliding present, but I had the impression certainly if I looked completely over the sternum that I saw A lines but no sliding. So I
Can
was
I,
just
can I,
wondering.
yeah,
Yeah,
I'll
yeah,
give
yeah.
you my 2p worth. So first, let's ask everybody else that right-hand slide. Who wants to have a go? It's the bottle of champagne question, guys. So please go for it. I promise I will ship it to you. So on the right-hand side, we have no sliding and an A- profile. Is that correct?
Yes, but there's lung pulse, I think, here.
Okay. Okay. Anybody else? Let's stick to the protocol. What does the protocol say?
But wing sign, not there.
Yeah. So there's no batwing sign. And were you over the bone, the sternum?
Yeah,
So
yeah.
if you're over
So
the bone and the sternum,
this is sternum.
yeah, what will happen to your sound waves?
Reflected.
They reflect back.
They'll be completely reflected back. So actually, from your perspective, all your deeper structures will naturally give you an element of reverberation from whatever soft tissue or bone you have. But really, what you're getting at this particular point is very similar to what you get over the stomach. There's no batwing sign, but often in that particular situation, you'll pretty much get what is called a pseudo A- profile, is what we call it. So in an ideal world, if you cannot see the batwing sign, then we shouldn't be actually commenting and assuming that what we're seeing below that is actually lung by protocol, by definition, based on basically what Daniel Lichtenstein says. Now, if all of you can see me, if you want to see retrosternal air, the only way to look at it would be to angulate your probe
We
through the
can't see
ribs.
you a lot. Sorry.
Oh, you can't see me. I'm so sorry.
Hello, can you mention which exactly this image you are describing, please, with cursor?
Yeah, sure. Okay, so this image that you see over here, okay, by definition, there's no batwing sign. So really, it's bone. And because it's bone, everything that basically comes here will be reflected back. There will be maybe an element of penetration because the sternum is not completely ossified. So by definition, we must not label this as an A' profile because really we don't know whether we're really looking at lung. Now behind the sternum in the midline, you'll actually have heart. So what I'd say is that we never, by definition, look through the sternum. There is an article that I'll send to all of you today, which basically looks at some of the newer science for describing pneumothorax, which basically looks at the incidence of diagnosis of pneumothorax in relation to the medial sternal edges. And just remember another article which basically says that if you're very near the sternal edge, often where the pleura interfaces with the medial part of the lung, there is less sliding. And you can actually get confused that near the medial ends of the sternum, there is evidence of a pneumothorax. There might not be. So my only kind of suggestion would be that by definition, and from what I've been taught, we never ever look through the sternum to try and make a diagnosis of air in the anterior mediastinal space. The only way to make that diagnosis is by doing a lateral view on the X-ray. And I mean, I'm just giving you an example of a baby who we had when I was in Southampton about 10 years back, who had developed problems with anterior mediastinal air, which was causing compression of the heart. And the only way that we eventually made the diagnosis was actually by actually doing a CT. So really, the diagnosis of mediastinal air is made on X-ray. By definition, we never diagnose pneumomediastinum. You can diagnose air leaks by using your probe at the medial edge of the sternum where the ribs align. But just remember, you can get false positive results because the pleural sliding is poor. Does that help?
Yeah, very
Yes.
much. Also,
Does anybody have any other thoughts? I mean, we've got a lot of experience. Dr. Ashraf, anybody else? Alberto, what are your thoughts?
Yes,
Anna,
it's the same. Sometimes when we do the cardiac ultrasound, one tip is when we can't see the heart very well, we can think about the external air as well.
Yep.
Because we lose the window. Yes.
Yep. That's a very good point. That's a very, very good point. So again, if you've got air in the chest, you lose the mediastinal window. You lose the window to actually see the heart. In particular, if you've got a left-sided pneumothorax, the apical view will be quite difficult to get. So that's a fantastic point.
Yes.
okay.
Please carry on. Any other images? Yep.
And then I looked on the left side, and there for me it was I had a batwing sign. I saw the pleura here. It isn't the best picture over here, and on the lower part it's better, I think, with small pleural line. I see the A lines, but for me it's an A- profile because I don't see any B lines or comet tails. And then I looked on the axillary line, and there
This is
for
definitely
me,
absolutely no doubt. Yeah.
It confirmed also for me the A- profile, but I looked on the posterior axillary line, and there I see the pleural sliding and with some A lines, but also a lot of B lines and some comet tails. And here for me, it's a double long point, where here I see the A- profile, and here it's an A
B.
profile with
Yep.
some B lines.
Yep.
Was my thought.
Yep. It's again, what I'd say is just with the eye of faith, the question is whether you do have a little bit of sliding there, and the M mode would be absolutely crucial in this situation. I'd say, yep.
Yeah.
But can I just say the image is a beautiful quality. Very nice.
Okay, thank
Good
you.
depth. Yeah, it's a lovely
Yeah.
machine. It's good work from your side as well. The machine is always secondary. It's the person who does the scan.
Okay, thank you a lot. No, so that was the case I wanted to present today. Yeah.
Lovely. Any questions about that?
No.
Any questions from anybody? Okay, we've now got Anne. Do you want to share?
Yeah, no bother.
Lovely, that's fantastic. And then we'll have Surjit and then Dr. Ashraf.
Can you guys see that now?
That's beautiful.
Perfect. Might just, hang on, I'll just start a slideshow, sorry. Perfect. Thank you. Sorry for the delay.
Take your time.
I'm going to admit my machine is not as beautiful as Pauline's. I need to put it in the bin and buy a new one, but that'll be my next job. I was going to present a little 24-week twin, a little boy, and he's been with us for a little while now. He's 2 months old, and he was born at 600 grams, and he's now 1.1 kilos. So he's kind of been having ongoing issues with regurgitation of feeds and vomiting. And at the weekend, he'd increased requirements on his CPAP. He nearly got reintubated, but he just about escaped. And he had some bloods done and a blood culture done, and his CRP was high. So this was his x-ray he'd had done at the weekend. You can probably see some background changes of chronic lung disease. He's not intubated on this. He has a line in his left axilla that's a short PICC line,
Yep.
and then right upper lobe opacification and his chest x-ray. So we haven't had very much pneumonia. So when I came into work the other day, I was very excited to see this x-ray, and everyone was laughing at me. So I got the ultrasound. These first pictures are actually of the left side, because this kitty, you know, is developing a likelihood of BPD.
Yep.
So I was just interested on the lung on the left. You can see, I felt the pleura looked, it was moving. I can see bat wing. The pleura looks a little bit thicker. You can see some A lines and some B lines as well on this. I felt, just took a couple. So this was anteriorly. Similarly, you can see some A lines, similar pleural findings, and some B lines present as well. And that's all the kind of his good lung. But I felt overall the lung on the left, considering he's a 24-weeker, he's 62 days old, has had time on a ventilator and is now on CPAP. I thought his lungs looked reasonably okay, considering the rest was what else was going on. And that's just left posterior. So this view, you can actually see quite nice A lines on that image, some comatale. The pleura's moving, looks a little bit thick to me.
Was he prone?
He was prone when I arrived to him, and so I scanned his back first and then moved him. So then this was what I could see on the right upper anterior. So what I can see here, I can't see pleura. I can see hepatization. I was a little bit nervous because, you know, obviously thymus as well. And I was wondering, you know, when I saw this kind of, there's bits where there's quite a sharp outline. I was like, you know, I think it's a pneumonia considering everything else that's going on. But again, I'm cautious and still learning. I thought the bronchograms, I thought they looked static. I couldn't convince myself there was kind of fluid moving in and out of them.
Yep.
And then I just one or this one. This is just transverse, so just in the same place, looking at it from a transverse point of view. So it looks like there's air bronchograms there as well.
Yep. It's a beautiful image. Both of them are very nice images. You have a lovely machine. Trust me, you know, the art is in your hand. It's never in the machine. So this is somebody with a good hand. So a lovely image. You can see pleura there, which is
Yeah.
established. I would agree that you're pretty hepatized at this particular point with static air bronchograms. So, the possibility of a kind of element of, I would say, definite consolidation. When you go back to the previous image,
Yeah.
it's a beautiful image. So I'd just say that there's some areas over here where the pleural line is not established. And as I've described, often you have a combination of consolidation with atelectasis. And the only reason I raise that is it's very well demarcated. It's very well demarcated. So definitely a consolidation, maybe an element of atelectasis with it. You've got static bronchograms.
Yeah.
The possibility that he's aspirated from what you're saying, very
Yeah.
high.
Yeah. Exactly. Yeah. And that's what my colleague on over the weekend was thinking about as well.
Yeah.
Um,
Just for everybody, again, what you basically sometimes see, and why I also think there's an element of atelectasis is that's the pleura here. And then this is so well demarcated. So often just with patchy consolidation or just a right-sided consolidation, you'll see established pleura here, which you can see in that particular region. So when you go to the next scan, and it's because you're scanning in one plane, but actually, when you look at it over a kind of a large area, you don't see pleura established, static air bronchograms. So this is the area of consolidation, and this is basically well demarcated collapse consolidation. It's beautiful.
So
Which
this is not
machine?
shred sign, right, Dr. Alok?
No, no, no.
Because
I,
it is regular, like
yeah,
not
yeah, yeah.
irregular.
No, no. There's no shred sign with the eye of faith. It can be pretty tough, but there's no shred sign. Uh,
Mhm.
which machine are you using, Anne?
it's a Philips machine. It's just the older version of it. But it's fine. Like
Yep.
it does the job, but we're just hoping to update it. The newer one doesn't have the small cardiac probe on it yet, so
Yep.
that's why we didn't buy it.
Yep.
Now, look, I
Please.
took a Doppler, but I'm not sure. I was looking, I guess, for blood flow, but I'm really not certain what I'm seeing. So
So a very good example of blood vessels is seeing them in a focal area. This kind of lights up everywhere.
yeah,
And for that reason, I'd just be a little bit nervous about kind of saying that there's increased blood flow in that region. Your scale at the moment is 4, is it?
yeah.
You probably want to get it to about 8 or 9.
Okay, perfect.
Yeah. And once you're using that, is kind of seeing whether you can see focal areas of blood vessels. On Sunday, when I show you images of lung recruitment, we'll show you a lot of areas of small focal
Brilliant.
consolidations, because really one of the questions that we ask ourselves over here for this kind of a baby is whether that area of lung will be recruitable or not. And because on CPAP, you might be able to put the PEEP up to recruit. Now, clearly, if the baby's with good gases and you could just give him time, postural drainage by keeping him kind of right side up. But if the
Yeah,
baby were deteriorating and you're worried that you might need a tube because he's got a high CO2 or rising FiO2, you can actually demonstrate reversibility by increasing your PEEP. And we'll
brilliant. Yeah,
talk more about it on Sunday, how the protocols for
perfect.
using and increasing PEEP.
Perfect. I
Yeah.
think that's yeah. And then this was just going on looking at the rest of the right lung, the rest of the right lung looked pretty similar to
Yep.
our findings on the left side.
Yep.
So I think that's all.
Very nice.
Yeah, sorry. Yeah, that was all. I was just excited to see a pneumonia because we haven't really had that many.
Yep. Was the
So
CRP elevated?
yeah, it was 101.
Yeah,
So
yeah,
it
yeah.
was
So
no,
clinically
yeah,
correlating, and that's where I'd say that, yeah, you're
yeah,
absolutely dealing with it. And it's just interesting. I mean, unfortunately, for reasons of confidentiality, I can't share the case with you, but I mean, it's just to give you an example. I've had a 24-weeker present exactly like you, going from air to 30%, just with a very similar kind of an appearance. And by 12 hours of age, we were oscillated, with
yeah,
very poor saturations, with a high CRP. And just going back to it, it was very, very obvious. We developed disseminated pneumonia with lots of
Yeah.
patchy consolidation. So what I'd say is that the mnemonic presentation here is a nice example of focal mnemonic presentation, but some babies can develop what is patchy consolidation with shred sign in both lungs. And a good example in our part of the world is gram-negative pneumonias affecting both lungs. And you just have a lot of shred sign with patchy consolidation as opposed to that focal region. So the presentation can be quite diverse. This is a really nice example of what is a focal mnemonic kind of consolidation with
Yeah,
athletics.
so he's been doing well this week. We haven't needed to intubate him, but I was gonna have a look. I'm on in the unit again next week, so I was gonna have a look and see kind of follow-up pictures
That
for
would
him.
be beautiful. What antibiotics?
He, I'm actually not sure. I
No
can't
worry.
remember.
No worry. It's okay. Would be
I
lovely
don't
to
want to.
see
I don't
the.
want to lie to you, so
It's okay.
I'll put it into the next time.
God bless you. That's great. Thank you so much.
Thank you.
Surjit,
Yes, Dr. Alok, I'll share.
Surjit, you can call me Alok. In our part of the
Yeah,
world, we
yeah,
use first names.
yeah, sure, sure. Yeah.
Nice cases, very nice cases today.
Is it visible, Alok?
It's visible, Surjit. You might just have to go to slideshow mode. So
Yeah.
just, yeah, God bless you.
Bullish.
Visible and audible.
Yeah, so this was a baby 10 days old. He presented with difficulty in breathing, and baby even had fever and history of cough.
Yep.
Just one second.
Surjit, you muted at the moment.
Yeah, just 1 second.
Sorry, my apologies. Just while Surjit is doing that, I'll be sharing an article with you by basically Rebecca Gregorio Hernandez about neonatal pneumothoraces and when they're in atypical location, in particular very close to the sternum, how we make a diagnosis.
Thank you.
Yeah, so when I tried to do the lung ultrasound, this was a picture which I got.
Hmm.
I could see skin, subcutaneous tissue, and the muscles, and
Yeah.
there's a barcode sign. Sorry, the bat wing sign is seen, and
Yeah,
at few areas, the pleural, there's disappearance of the pleural line.
yep, you're absolutely right.
Yeah, and I can see an AIS pattern, and that
At
is
the
B
bottom.
profile.
Yep,
And I can see a shred sign
you're right.
with
Yep,
irregular margin.
yep.
The two parts
It's a beautiful image, but not for the baby. Yeah,
Yeah, not for the baby.
So you've even
So
got some dynamic air bronchograms coming
yeah,
in and out.
yeah.
Yep.
Alok, like how do I say these are like air bronchogram look white, I
Mm.
mean blackish, and the fluid bronchogram is supposed to be ecogenic, right?
No, it's the
So how
opposite.
do you
The air bronchograms are bright because air is a good reflector, but fluid will let sound waves go through it. So often fluid will appear dark. So
yeah, fluid will appear, sorry, black,
yeah,
right?
yeah,
And air will be ecogenic,
yeah.
white. So like so
S-
these are white
Yeah. So
bronchograms. So
they're
these are
basically air
air,
bronchograms.
right, right.
Now, if you look with the eye of faith, this goes in and out. So I just wonder whether that's a dynamic air bronchogram that you see. That
I think the baby is having distress and baby is moving
sure,
a bit, maybe
but
due to
the
the
rest of the
distress.
areas, they look very static.
Yeah, I'll just play it again.
Yeah, sure. So like if I draw out,
Yeah, this is
this is a
another.
classical fractal sign. Pleura is destroyed, very irregular. These are small areas of subpleural kind of consolidation that you see over
Yeah,
here. The question is whether that area that moves in and out, are you able to play it just more, once more?
yeah.
Sorry, this area here. I mean, it appears and disappears, doesn't move in and out. So it's probably a static bronchogram. Yeah, it's
Right.
easier
So
to
we
see
had
now.
treated this, given respiratory support and antibiotics, and
Yeah.
baby got better with that. Yeah.
What was the CRP?
CRP was also around 75 or
Yeah,
something.
very suggestive. Did you put Doppler on it?
No, I didn't.
No problems. No problems. It's very, I mean, the history and everything would suggest that's very bad fractal sign. Yeah. Very nice images.
So there's another case.
Please.
This was a baby, a term baby with birth asphyxia, came with respiratory distress on day 2 of life. And baby was on mechanical ventilator support. And this was a lung ultrasound. And here I can see a bat wing sign
Mm,
and good lung sliding
mm, I
and
agree.
A
See
profile.
condyles. Yeah.
Yeah, and I can see A lines.
Yep.
And in the next picture on the another side, this was the image. So
Mm,
the bat wing sign is seen, but the pleural sliding is absent.
mm,
And it's an A dash profile
mm,
and with no B lines, no comet tails.
mm.
And when I put a M mode on this, I
Yeah.
could see
Yeah.
this. So this is
Classical
a
barcode sign.
barcode sign.
And again, just to highlight the real importance of depth, why is
Yeah.
it so important to see the barcode sign? As I was saying when Dr. Ashraf said, because you've got depth, you've got A lines going through all the way. So basically, this is where you're seeing subcutaneous tissue, which is giving you the profile. That's the pleura, that's the reverberation artifact that you can see all the way through. This is your classical barcode sign. Now, the problem is if you lose your depth and you have just 1 or 2 A lines, you will predominantly get what is your, I would say, shore. But in terms of the sandy beach, if the distal lung is okay, because they're sliding, so the shimmering of the pleura gives you that sandy beach appearance, and it's because of reverberation artifact moving down. So if you lose the depth of your image, the risk is you'll really not be able to see what I'd say is the sandy beach appearance. Hence, the depth is quite important. But this is, yeah, classical barcode. Yep,
So another one, this
very
small
nice
presentation.
images. Which machine, ma'am?
This is sonocyte and This is another baby. It's a term AGA baby presented with severe respiratory distress. So as the baby had low saturations, we had to intubate the baby and put on conventional mechanical ventilator. So I thought of doing a lung ultrasound. And when I put my probe, so this was a picture. So there was a batwing sign, definitely, but I couldn't see A lines, I couldn't see B lines.
Yep.
So this was more of a tissue-like
Yep.
or maybe intestines.
So my worry is intestines.
Yeah,
Yeah, because I mean, just the uniformity of the appearance. So is this
yeah.
left or right?
I'm not very sure.
No problems, no problems.
Yeah.
So in particular, when you look at the loops, that there's just some visible kind of loops there. So I would,
Yeah.
yeah, just there. I would really be worried that's intestine. I mean, what I'd say is that just for everybody, sometimes you will not get visible loops because you've decompressed, taken air out, and it gives you that kind of appearance that can confuse you with tissue signs. But really, uh, the one thing that's a giveaway for me is I can see peristalsis. So can you see peristalsis just in the center? So I'll just highlight that for you. Yeah,
It's
there's
just,
peristalsis over here. So I'd be a little bit worried that you've got a diaphragmatic hernia. Yeah,
yeah. So this was a case of congenital diaphragmatic
yeah,
hernia. But
yeah,
in this
yeah.
area, I think I can see a bit of A lines.
Yep. Sorry, I'll just wipe the rubber off. Yep. So there's a little bit of lung there. And just be
Yes.
aware that, as bowel loops migrate up, the plane in which we do the ultrasound can sometimes make it a little bit confusing. You can sometimes see lung below, above, and it really depends on the plane in which bowel is being seen. Because if I talk three-dimensionally, bowel can actually be in front of lung. Bowel could be lateral and compressing lung, but you might also have lung anterior with bowel actually posterior. The posterolateral part of the pouch may have bowel that's actually posterior to lung, which may make it very difficult sometimes to actually visualize bowel until you actually move laterally. So that is why a comprehensive scan is very, very important. I would say that if you see anything that doesn't look like tissue, that makes you feel odd in its appearance, that Nadia said looks a little bit cystic, please always do comprehensive scans in that situation. And again, on Sunday, I will talk to you about, we haven't talked about what a sweep is. A sweep is basically a very easy way of moving down on the chest, going through each intercostal space to visualize everything. And then in certain machines, you have what is called extended convex views, which means you can get the whole of image, anterior, lateral, and posterior in just one view. But I'll show you how to do that. If you have a sonosite, you should be able to do it. If you have a GE, you should be able to do it. I'm not entirely sure whether the Philips does let you do that. Please carry on, Dr. Surjit.
Okay. This another case, this is a term baby with a history of meconium aspiration, presented with severe respiratory distress. On day 1 of life, we had to intubate the baby. And this was a lung ultrasound picture. So here I can see the bat wing sign.
Yep.
But the pleural line, the lung sliding is seen, but the pleural line is discontinuous and looks disrupted.
Yep.
And there is subpleural consolidation,
Absolutely.
and there is confluent B lines.
Yep.
So is there some pleural effusion
I
also?
do
I was
think
not
there's a
really
little bit
sure.
of pleural effusion there. I
This
think you have a
area.
pleural effusion. So the best way to confirm that, because it can get quite confusing, is use your M mode and look for the sinusoid sign. If you see a dark
Okay.
area, so normally if you see pleura, you should technically in this situation with sliding, you should get a seashore sign with a very grainy kind of a sandy beach below. But if you see a dark area, which is called the sinusoid sign, it should be visible. Now, because the pleura will move, visceral and parietal pleura will move on itself, it kind of gives you a sinuous kind of an appearance. So again, just use your M mode if you're confused, but I think there's an effusion there. Absolutely no doubt. Yeah.
A few spared areas also here.
Yep.
This is another area.
Very nice.
Almost similar picture in all the areas.
Focal consolidation. So
Yeah.
again, a really nice hallmark there. So that's a focal consolidation. Might be a fractal sign. And again, it's just to say that fractal signs can be seen in meconium. They can be seen after pulmonary hemorrhage. Uh, I mean, theoretically, you can have babies who've had earlier mnemonic kind of presentation treated with antibiotics who then develop chronic lung disease, and the CRPs aren't elevated, but it's taking time for the fractal sign to heal. So it's not pathognomonic of pneumonia. Clinically correlate, look at your baby, and then really what I'd say is decide.
So
Very
in
nice
pulmonary
images.
hemorrhage also we have focal patches, fractal signs.
What I'd say is that what you see with pulmonary hemorrhage often is a reaction to blood and hemosiderin, which causes lung necrosis. So it might, in an acute pulmonary hemorrhage, what you might just get is AIS, white lung, bilaterally everywhere. But with time, as you ventilate, what you'll find is as things clear, you then start seeing fractal sign. And again, a lot of people sometimes feel that that might be evolving infection. And I think if you treated that baby with antibiotics at that point, you wouldn't be wrong. But Jing Liu has described it uh, quite often in his experience while seeing babies who have pulmonary hemorrhage, not immediately, but maybe a day or two after. And it just indicates that you probably have had a reaction, an element of lung necrosis after the hemorrhage, which is presenting in that region. It can be focal. It can be quite extensive as well if it's really bad. So what I'd say is that my take-home message is, I mean, this is very classical. You've got a history of meconium, but fractal sign in isolation is not always indicative just of mnemonic kind of clinical presentation. It can be seen with pulmonary hemorrhage, can be seen with meconium aspiration, can be an all healing mnemonic kind of presentation. These are very nice images, very good depth penetration. You're using the full depth. You're using a linear probe, which is very
Yes.
nice. So it's giving you such a good footprint. You're having so 1, 2, 3, nearly 4 ribs. And that's the beauty of using the linear probe as opposed to the hockey stick, especially in a big baby. It'll give you much more anatomical definition.
And in pulmonary hemorrhage, do we have that uniform kind of whiteout lungs all the
Acute.
time?
I think if you had an acute pulmonary hemorrhage, yes. And
Acute.
again, it's clinical correlation. So there's nothing that's really pathognomonic of it. If you have blood coming up the ET tube, in some babies, there's this description of silent pulmonary hemorrhage. So if you have an acute deterioration, really the challenge is, have you got a previous lung ultrasound that demonstrates that you had well aerated lung, which suddenly develops AIS or white lung in every region? The baby's ventilation has gone up significantly. Uh, and really suction reveals a very small amount of blood. I mean, those are babies who might be having what we call as a silent pulmonary hemorrhage. Having the previous ultrasound helps. And for units like Almudina's, where they're doing serial lung ultrasound, naturally they're more likely to be able to make that diagnosis. In your case, if that happens and you don't have blood up the ET tube, I think you'd end up with a differential. You'd consider infection. You may consider wanting to recruit lung. And again, we'll talk about patterns. The question is, can we recruit lung and change either the pattern of AIS to a B to an A profile, or do you have an S pattern, or do you have atelectasis that can be recruited? So we'll talk about recruitable lung. But there's no pathognomonic or typical appearance of pulmonary hemorrhage. It's really the history of having clinical signs and symptoms of a hemorrhage through the ET tube and then correlation.
Right. That's it along these
Lovely,
4 cases.
beautiful. So nice. Thank you so much. Does anybody else have, so Dr. Ashraf, I'm so sorry, Dr. Ashraf, please.
No problem, no problem.
God bless you. I think
I will,
Dr. Ashraf has an absolute treasure trove of cases.
is feasible and edible.
Visible and audible. Yes, sir.
The first case is done early term male neonates 38 week, normal vaginal delivery and booked mother with brom 27 hours. Respiratory stress in delivery room, the weight it was 2.9. Ultrasound done at 1 hour of age of life. for assessment because you did X-ray, I know this is the left congenital hernia, to assess the lung, and I will scoring for this is congenital developmental hernia lung score.
Yeah.
الايكو with multiple pulmonary hypertension, left renal agenesis, minor dysmorphic features, السنابي after 12 hours it was 49. At 12 hours of life, at 12 days of life, TLC it was 37,000. CRB it was 270. CH repair after 24 hours, and discharge home after 21 days. Hospital went to pneumothorax, sepsis, and pleural effusion.
Sure.
Because the small fissure and left agenesis and hernia, I advised the family to do with.
Yep.
This is the scan, the left anterior upper. So when this is the some gut here, and this is spleen part, spleen.
Yep.
Here برضو the gut moving and like this. في batwing sign here. Batwing sign because you have now in the underneath and in the thoracic cavity.
Hmm.
In two intercostal space, no border line. Here. No lung sliding with no A line in L1 and L2.
Yep.
Presence of gut inside the left hemothorax, presence of the spleen inside the left hemothorax. You know,
Yeah,
this is the stomach.
peristalsis. Yeah.
Yeah, this is the stomach. Yeah.
Yeah.
And you know that. I think this is the stomach.
You're right. I mean, this baby would have been nil by mouth, right?
In
Nil by mouth at this stage.
First start with what the bubble, and I don't really understand.
No, my question is, this is antennatally diagnosed, so the baby would have been nil by mouth.
No.
This is a
This
postnatal
unbooked
diagnosis.
mother. Unbooked
Okay.
mother, yeah.
Okay.
Between the sign there, so it is inside the lung and the thoracic cavity. There is
Sure.
stomach here.
Yeah.
There the other lung, the right lung, with
Yeah.
the score, bit normal. ولا A pattern.
Hmm.
This is another baby,
Hmm.
but I just to show the diaphragm. The diaphragm here incomplete.
Very nice.
They went to in the beginning after repair. 24 hours, they go to the pneumothorax. You have
Yep.
here lung point and this POCUS sign. After maybe 5 or 6 days, you
Pleural
get to
effusion.
the fusion. This is
Yep.
atelectasis, here atelectasis, and this is the fusion. And this is before the charge.
Yeah. Very nice. Beautiful.
This outcome, this is admission. You have here spleen gut with after at charge home. It's complete normal lung. We talk about, I found the article by Italian group, did congenital hernia lung ultrasound score, lung ultrasound score.
Hmm.
He did the Brad score, but we added another score for presence of organs inside or post-operative pleural effusion. فالتوتال سكور between every lung 24 and 24 it will be 48. It is mild score from up to 12, moderate from 13 to 24, severe above 25. Our patient it was 16. Like there. يعني this is L1 take 4 because organs, L2 take 4 because the gut,
Yep.
L3 0 here because normal lung, L4 get it 4, Also L5, but I noted here, get it 4. It all total 16.
Dr. Ashraf, do you have a reference that you could share with the group for it? It would be lovely.
Yes, I will get the paper. I will send it
God
in the
bless
WhatsApp.
you. Thank you so much.
This is the X-ray before repair, and this is the ultrasound. This is 1 day after repair. This is pneumothorax. This is at this time the SRB raised to 270. This is complete consolidation here,
Yeah.
ossification. I will put
Pleural
ultrasound
effusion.
with B fusion, and this is on discharge. Uh, So the diagnostic criteria of lung ultrasound of CDH, partial absence of diaphragm, what you are so partial absence of the pleural line in affected hemothorax, absence of A line in affected area, presence of multi-layered area with hyperecho content in motion, this is normal gut, or presence of organs as spleen or liver in the thorax. That's for the first one. The second one, can I go to the second one? Any question here?
Any question, folks? Please go ahead, sir.
I will new share. The second cases is media. Because this is have a good image. This one. Yeah.
You'll have to stop
Visible?
share. No, stop. Yeah, that's it. Now visible. Yes. God bless you.
Yeah. Okay.
Thank you.
Sorry, this is media patient, but I have a lot of sign there I presented.
Please.
This is 56 months, almost 6 years old female, completely healthy before this presentation. No previous history of illness. He came to OPD clinic in this case of liver pneumonia, transferred to the other clinic. She had history of fever, cough for 1 week, and fast breathing in the last 24 hours. Admitted from the OPC with liver pneumonia and massive left side consolidation. Diminished breath found and dullness in the most area of the left lung. الهيموجلوبين at this time it will 10, الهيماتوكريت 31, الWBC 50,000, النيتروفيل 80%, البليتلت 1,300,000, CRP it was 280. الشيست اكس راي revealed the massive left-sided consolidation. He did contrast enhanced CT chest, revealed marked left pleural effusion and evidence of necrotizing pneumonia. الفocus to assess the lung and diffusion. This is the X-ray in the presentation. See all left lung obesity. See some area here of irrecency.
Yep.
Yeah. And medium external shift to the left side. In contrast, CT, enhanced CT, it is just best effusion and the area of necrosis here. Cystic lung here, here, and here. So ultrasound, I think for the effusion better than the CT because we dilated the septation or not septated. I will show you. I did ultrasound. This is the hang. I will start
Yes,
with the
please.
hanging.
Yes.
Yeah,
Okay.
because of the hang. The hang. So I will. I will stop. I start again.
Yeah,
Okay.
please. If anybody has any questions while Dr. Ashraf is sharing, any questions, any doubts?
Visible now?
I think just opening.
Visible? It's okay now?
Not at the moment, no.
Is okay visible?
Yes, visible now. Yeah.
Yeah, I did ultrasound. We found this is the area in the all lung, upper, lower, axillary, lateral, posterior, the same. Found there is septation. This fluid, echogenic fluid with septation, and this is fibrin. This is not the lung down.
Yep.
This is fibrin,
Exudate.
fibrin septation or fibrin formation. Complex thick and thin loculation with the fluid and multiple septation with the solid appearance component. No broad line, no lung sliding. The same area. All lung like the anterior mid. There's a fluid septation with solid component, septated with solid component.
Yep.
Beautiful septation there. This is very hard to this is complex, and this is very solid area.
Yep.
And the septation. This area was necrosis, this area in the CT, So طبعا I cannot with ultrasound check the necrosis because all area, even no
It's
consolidation.
completely necrosed. Yeah, you're absolutely right.
Yeah.
The lung is destroyed. So, did the girl lose the lung?
لا, I will use
Sure.
you. This
My
is
apologies.
the this is M mode, this side. If you know, there's a two pattern. One pattern from the fluid and pattern from the fibrin here.
Yeah. That you see at the top there, the pattern from the fibrin strand. Yeah.
Yeah, the other one was fluid.
Yep.
This is the lung here, and it's collapsed here now. Completely, يعني almost all fibrin, يعني it's almost fibrin. This is the ipsilateral lung, right lung, completely normal. By يعني this is the difference between left anterior upper and right anterior upper. This is posterior and posterior. What will this patient he cannot do simple chest tube. It
No,
either
absolutely.
go to either go to the fats يعني في septal cystoscopy or chest tube intrabular streptokinase infusion. I didn't have thoracic surgery in our hospital. I transferred to the tertiary hospital. What he did cardiothoracic surgeon. He did chest tube, infused 3 days streptokinase, but still the patient not still some fluid, some septation. They go to the open, made decortication, and the patient go home well.
That's amazing images. Yeah. That's really kind. Thank you, Dr. Ashraf. I'm so grateful. So what we're going to do just before we leave, just 2 minutes to say what we've had a slight change in schedule. So I will be covering lung recruitment on Sunday. I am keen for us to do some peer review. So if you have any cases, we will spend about, I'd say 30 minutes doing cases and about 60 minutes doing lung recruitment. And then the next Thursday, I will be covering pleural effusion and chest drainage, the actual procedure. So actually how to use ultrasound while actually diagnosing, but more importantly, for placement of chest drains. And really what we'd be talking about is a step-by-step approach. So those two topics, I mean, for those of you who can't attend as usual, I will share the recording with you. So there'll be 2 videos that'll come out this weekend, one by Nadia that was done last Sunday and today's video, which will be up on Saturday. Thank you all for your patience and your hard work. I'm grateful.
Thank you. Thank you. Thank you.
Thank you.
Thank you.
you.